And I'm here at the Deuk Spine Institute and Surgery Center Vieira. We're getting ready to perform our first surgery of the day. We live stream all of our surgeries so you can watch and ask questions. We'll be performing a repair of 3 herniated discs in the lower back. Let me just talk to my patient for a moment. Okay, we're ready to get started, okay?
Sarah?
We're ready to get started. All right, just lay still. I'm going to give you some numbing medicine, all right? If you feel pain, say ouch, but don't move around. All right, Sarah? All right. So left side is 4-5, correct? So we're going to be doing surgery on both sides. Just lay still. You're fine. That's the numbing medicine going in. I apologize. I know it's not comfortable. You're fine. Everything's okay, I promise. And then on the right side, it's 5-1 and 3-4, correct? Everyone's in agreement. A little stick and burn. You're all right. That's just numbing medicine. I apologize. Okay, so first thing we're doing is we're just numbing up the skin so that we can make it more comfortable for our patient. Just lay still. You got to lay still, all right? It's very important. So on the left side, it's L4-5. Everybody in agreement? So how's blood pressure? It's good. If we could bring it down just a little bit, that would be good. All right, so this patient has 3 herniated discs, and let's go for a lateral view, please. And so our goal here today is to repair 3 herniated discs. Now, these discs are causing back pain and leg symptoms, as most herniated discs do. When people have a herniated disc, it usually causes back pain with or without leg symptoms. Not everybody has the leg symptoms. What are leg symptoms? Numbness, tingling, weakness, and pain. 4 things. And not everybody has all 4. So everyone's different. Some people have 2 out of 4. Some people have 1 out of 4. Some people have 4 out of 4. Most people don't have 4 out of 4 symptoms. Most people have pain and weakness, or pain and numbness and weakness. Tingling is not that common. It's the least common of the 4 symptoms of the legs. Now, what the leg symptoms are due to is they're due to irritation of the nerves in the spine. Let's get some more numbing medicine, please. So the nerves that go down your legs that give you feeling and strength and bring pain signals up to your brain, those nerves, I'm just giving you more numbing medicine. You're fine, just lay still. Yeah, so Rafferty, it'd be nice if you could make it a little more comfortable. All right, in the very beginning. Well, whatever it takes. I need them cooperative and comfortable. Yeah, you're doing great. Everything's fine. This is the worst part of the surgery in the beginning when you're awake. So the patient needs to be awake. Some people wonder why. Because I need their help navigating to that spot where the pain is coming from. That's why patients are awake. All right, we're aiming for L4-5. That's the L4-5 disc I'm going towards. I'm right near the facet joint. I have to navigate around it. It is a little bit arthritic, but that is not the primary source of pain. I believe the disc herniation is. So let's get back to the symptoms that disc herniations can cause. The most common is pain in the back or neck or thoracic. Depends on the part of the body we're dealing with. So we call it axial pain because the spine is the axis. It's the axis of the body. And the most common symptom from a herniated disc is pain in the back or pain in the neck. Depends on where the herniation is, obviously. Sometimes the thoracic spine has herniation, so that could be a a source of thoracic pain. Shot. So I like to come in low in the foramen. You comfy? Yes. Shot. All right. We're aiming once again for L4-5. Shot. All right. So we've accessed one disc. And the beauty of this procedure, unlike typical spine surgery where the surgeon makes the incision in the middle or just to the side, all those surgeries that other doctors do require damaging the muscles of the spine. There is no surgery that doesn't damage the muscles of the spine except for this surgery, the endoscopic transforaminal approach. So this surgery is very good at preserving the muscles, which are very important because the muscles are the source of everyone's pain after surgery. Shot? All right, we need to get 5-1 looking really crisp. Let's bring the fluoro south. Before I try to navigate to the disc herniation at each level, I want to make sure my X-ray machine or fluoro machine is lined up perfectly so that I have accurate information. Remember, the spine is three-dimensional and the fluoro pictures are two-dimensional. You don't get any sense of depth, but you have up and down and side to side information, front, back, and top to bottom, but you don't have that three-dimensional information. You're going the wrong way. So let's just look at the MRI. 5-1 disc is pretty collapsed, but it should be accessible. You got to open that foramen up for me, Jordan. You're not horribly off, but maybe it's a orbital issue. Keep going. So right now we're spending some time. Keep going. Did we go past it? We want to line up our machine so that the pictures we're getting, I think you went past it. Pictures we're getting are accurate representations of the anatomy three-dimensionally. I think you're close. That's worse. So give us a minute to get our navigational information right. This would be if you're navigating on a boat at night 200 years ago, 300 years ago. It would be like using the stars and a sextant. So you're using reference points to navigate. And our reference points are the bones of the spine. And everybody's bones are a little different. Some are bigger, some are smaller. So we need to line the bones up properly in order to get a good view of the place where we're trying to go. I think you need to wag 1 degree because the pedicles of 5 are not lined up perfectly. So let's get the pedicles of 5 and the end plate of 5 lined up, the inferior end plate. Pick one way or the other. Take a shot. I don't know. Does that look better to you, Luis? It kind of does, but I think we're off orbitally. If you look at the pedicle, we're off orbitally by about 1 degree. So what we're changing is the wag and the orbit of the fluoro, and then we're also translating along the floor. I still think we're off orbitally, but I can't tell if it was better or worse. I wasn't looking. Go ahead, do it again. I think that's better. Try a little more. So think of it as trying to get a profile. That may be our best. I don't know. It looks like it's the best one that I've seen. What do you guys think? Yeah? So think about what we're trying to do is get a profile of a person, right? You've all seen profile pictures of people. And what you see is the chest, side view, perfectly profiled, the head, the neck. But imagine doing a profiling of somebody, a profile silhouette image or side view, but their head is turned, but their body's not. Their body's forward, the head's turned. So now you're going to change your camera angle to get the head on a profile, but then the body and chest are not, right? Because they're twisted relative to the head. That's what happens with scoliosis. So we're sitting here trying to figure out the best angle, but we're dealing with rotational issues of the spine. So the L5 is rotated relative to the sacrum below. And that happens quite often because L5-S1 is the second most common disc to degenerate. And when discs degenerate, they can rotate. The bones can rotate. Okay. Are you comfy?
Sarah, you comfortable? Sarah?
That's fine. Yeah, I don't need Sarah's cooperation this very second. So just keep Sarah comfortable. Sounds like Sarah is comfortable. Sean? I will need it soon, but not right now. All right. Let's get a AP view shot and then AP. L5-S1 is the hardest disc to access with this technology, transforaminal. So for those of you watching the surgery, you're watching the most state-of-the-art surgery in the world to treat herniated, bulging disc, degenerated disc, all three. Herniated disc, bulging disc, degenerated disc. And bulging discs are really the same as a herniated disc, just a small herniation. And degenerated discs are the same as a herniated disc, but over time, the inflammation that goes on in the disc causes destruction of the disc. So if you have a disc herniation that's painful, despite everything you've heard, do not wait to get it fixed, because this is the only surgery in the world that actually repairs the disc. And the repair that I do fixes the source of inflammation in the disc. All right, so by repairing the source of inflammation in the disc, we're able to eliminate pain, but we're also able to stop the degeneration of the disc. Where do you feel that?
Sarah, where do you feel
Shot.
that?
Where? In the back?
Right in her back.
All right, that's good. Everything's going good. Let's get an AP. So, just so you know, folks, if you're having a herniated disc, bulging disc, degenerated disc, and you're having pain, if you go to your doctor and ask them what treatments are available, they're only going to tell you what they do. And they may do fusions, microdiscectomy, laminectomy. These are all old-fashioned surgeries, and they're highly destructive and damaging to your body. If you don't believe me, just look at the size of the incision that the surgeon makes. It's big. We're going to do all of this surgery through tiny little 7-millimeter incisions endoscopically. And more importantly, we're passing through the muscles and tissues, not tearing them open, not cooking them with bovies and bipolars, and not shredding them with knives and metal instruments. We're delicately separating the tissues under the skin. So truly the only scar in this whole surgery is going to be the skin, as opposed to microdiscectomy, laminectomy, fusion, artificial disc. All of those surgeries are massively invasive, bloody, painful, destructive to everything inside your body that shouldn't be destructive to. All we're trying to fix is one little small area in the disc, and all those surgeries involve taking the whole disc out, making huge incisions, manipulating your blood vessels and tearing muscles and fascia. Okay, so this surgery is the least invasive of all of them and the most successful with the fastest recovery rate.
Okay, Sarah?
She's fine. Yep. You're doing great. I don't know if I can get, yeah, maybe I can get 3-4. No, we'll try. Maybe we'll do this with 2 incisions. So, what's the secret here to our success at Deuk Spine Institute? There's 2 things. Number 1, well, 3. And really the third is part of the second. Number 1, you have to have the right diagnosis that causes pain. Why is that important? Because pain, there are 32 causes of pain in the back, 32 potential causes. And I have to look at every patient that comes to me with back pain and figure out, all right, well, which cause is singular or plural does this patient have? And the most common cause is a herniated disc, bulging disc, degenerated disc. It's all a disc issue. Discs are by far the most common cause of pain. So then, what else could cause pain? Well, if you notice, there's a fractured bone on this x-ray. So we tested that to make sure that wasn't the cause of pain, because I wouldn't want to be operating on someone's disc when the cause of their pain is a fracture. Okay, because fixing their disc won't fix the fracture. So we had to make certain that the fracture was not the cause of pain before we recommended treatment, because fixing a fracture is different than fixing a herniated disc. So we determined the fracture was not the cause of pain for this patient, and then we recommended fixing the discs, which are the cause of pain, in my opinion, based on the patient's location of their pain. We're almost done, by the way, and we're going to be able to put you to sleep soon. Everything's going perfect, okay, Sarah? Okay? All right, I almost made a boo-boo, but I didn't. I'm not surgically a boo-boo, but from my oral orifice a boo-boo. All right, so I am very close, and I think I'm looking for the facet here at 3-4. So if you look at the x-ray, we've managed to place needles at 4-5, 5-1, and then now I'm doing 3-4. And that's okay to say. Shot. You feel anything there?
Sarah, you feel anything there? Sarah, you feel anything?
Let's avoid names. Anything?
Anything there? No.
All right, let's get an AP, please. So you can see the tip of the needle is in the neural foramen. And that's the beauty of the surgery, is that we're actually coming at an angle from the side, so we don't have to remove bones that are normal in the spine. Yeah, we need to be a little bit more medial. Let's go back to a lateral view. We don't have to remove this patient's bones or ligaments. So traditional spine surgery that surgeons do requires they remove the bones of the spine. You're fine. Everything's good. We're almost done, I promise. Shot? 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 Let's get an AP. Diego, do you mind showing the audience how herniated disc cause back pain? Can you run that animation?
Can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for a free review at www.
You're back.
Okay, we're back with you. So you just watched the animation on why people have back pain from a herniated disc and also leg pain. Shot. We're still here navigating to the L3-4 disc through the right foramen. Now we're going to show you next kind of a comparison of laser surgery that we do here versus open surgery like fusion. Anything?
Right leg.
Invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, two patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a half an inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin.
You are back.
So at this point, folks, we're getting ready to actually do the surgery that's going to repair the disc, which is the endoscopic part of the surgery. Before we do that, I had to, step one, prep and drape the patient. So position, prep, and drape. We sterilize the back so there's no infection that can happen. We use a sterile field, standard for surgery. Then we had to access the tears. So we're here to repair tears that are happening inside the back of the disc. And every herniated disc in the world, every bulging disc, every degenerated disc starts with an annular tear. It's an annular tear, okay? And that's the wall around the jelly. So this patient had 3 annular tears, one at L4-5, L3-4, one at L4-5, and one at L5-S1. Now through the tear, the jelly in the center, the nucleus, squeezed out and got stuck, and it's causing inflammation. That's where the back pain comes from. We're gonna unstick that jelly and remove it with the laser. And then we're gonna clean the tear up, get rid of the inflammation in the tear, and then we're going to also unpinch the nerve root that's being pinched. And not everybody has a pinched nerve root, not every disc has a pinched nerve root, but when people have leg symptoms going down their leg, when they're up standing and walking, that's usually an indication that the nerve root is being pinched or irritated. So we're going to fix the nerve root problem to get rid of leg symptoms, and we're going to fix the back pain, all with this procedure. Are you comfortable? Remember, the patient's awake up to this point. Are you comfy? All right. How bad is that on a scale of 1 to 10?
How much is it? 3.
All right. Actually, that last part got some of the posterior tear because I think I was in a little far. All right. Is that where you typically get pain?
Yes.
Yeah. So he calls it a 3 out of 10 concordant. So that is L4-5, but I think because mostly I was a little more anterior in the disc, that's why we didn't get the posterior experience, which works out in his favor. Sorry, her favor. All right. We're almost done. Now this one was painful to get into, so I believe this is going to be a more painful disc. How bad is that on a scale of 1 to 10? 10. All right, so if you look at this one, Jordan, would you mind pointing to the tear? Look at the size of the tear in the back of the disc, right there. Okay, that's a huge tear. All that dye, the black stuff, is leaking out through the tear, and that's where the pain comes from. And the disc before at L3-4, I didn't get very much dye to leak out through the tear because the needle is a little bit more in the front. So, but that's a 10 over 10. And that's where she typically gets pain, sorry. So that's definitely, that pain will be gone when you wake up. That's the good news. All right, we have one more disc that we're going to test today. And we don't just do this to test the discs to see if they're painful. We also do it because we're wanting to visualize the tear, see how big it is, so that I can plan what I need to do surgically. How bad is that on a scale of 1 to 10? 11? All right. So L5-S1 was an 11. Good news, you get to go to sleep now. When you wake up, your surgery will be over. And that pain will be gone. All right. Can you count from 1 to 100 out loud for us, please? So while our patient is counting out loud, the anesthesiologist will put the patient to sleep. We use propofol. Of course, the patient's not intubated. They don't have a tube down their throat because we need to talk to the patient during the surgery, like right now, what you saw. But also, there's no need to put the patient under general anesthesia for this type of procedure. It doesn't require it, so there's no real advantage to doing it. Our patients get what's called twilight sedation for the lower back and for thoracic disc herniations. Now, this surgery can be done for thoracic herniations as well if people have painful thoracic disc herniations. Most disc herniations that are painful happen in the lower back. And we just tested these 3 discs. All 3 of them cause the typical pain that this patient experiences. So I think this patient's going to be very pleased with the results of the surgery. We decided to do L3-4 on the patient's left side because she actually has left leg pain as well as right leg pain. So if I did all the discs on the right and didn't do the left, I wouldn't be able to treat the left leg pain that she's having. So we're going to start with L4-5, left side. I'm placing my guide wire. We're going to use the x-ray machine to kind of monitor the progress. Okay, so I believe that's the guide wire there. Let's just take one more x-ray. Are you pulsing?
Yes, sir.
All right, good. So pulsing means we're using less radiation. A lot of surgeons don't care. They just full blast the radiation. They use tons of it. But radiation for x-rays is really necessary to do surgery on the spine. However, it's also, you know, radiation's not a good thing. We don't use high dose radiation incision. We use low dose, but it's cumulative. So for a patient, it's not a big deal unless they get a lot of x-rays. But most people don't get enough x-rays in their lifetime, not even close, to having to worry about the effects of the radiation on their DNA. However, the staff, like myself and my team, we have to be concerned about it, so we wear protection, okay? And that protection comes in the form of lead or lead impregnated things, okay? So radiation can affect your lens in your eye and cause cataracts, which many people get anyway. Radiation can also affect your thyroid gland and cause thyroid tumors, okay? Even cancer of the thyroid. So that's why we wear a thyroid shield during surgery. All right, at this point you can see just in front of the dilator that there's dye in the spinal canal and it's running around the dura, in front of the dura, not in it, but in front of it. It's leaked out from the disc tear, but you can see how just as the dye has gone out of the disc and spread up and down the spine, so can inflammation. So the inflammation happening in the back of the disc and the tear, those inflammatory mediators, cells, cytokines, interleukins, all that stuff, that juice, inflammatory juice can spread, all right, and get on nerves and the fecal sac, and it can cause horrible pain. Now this patient has a lot of scar tissue here. I can feel it, okay? And that's probably why this disc didn't have a big tear, because it's mostly been healed. But we know that there's narrowing on this side that's impinging on the nerve root, causing some nerve damage. So we're going to go in there and fix that. I see the guide wire is moving just a little bit forward. I'm going to pull it back just a little bit. I don't want it going into the pelvis. And then I'm going to come back and shot. All right, so at this point I'll take the guide wire out and we'll just advance shot. All right, so we're in the L4-5 disc on the left side. We're going to repair this disc first. Left L4-5 repair first. So the whole surgery is going to be done through this tube that I'm placing right now. That's how minimally invasive the surgery is. This surgery replaces spinal fusions, A-lifts, T-lift, P-lift. This surgery replaces laminectomies and microdiscectomies. You don't need to have a laminectomy done. You don't need a microdiscectomy. They're damaging to your body and your spine. You don't want a microdiscectomy. We're going to show you soon in a video that we're creating how microdiscectomy ruins your spine. The surgery itself ruins your spine. You understand? The whole goal of a microdiscectomy is to go in and pull out a herniation that's pushing on your nerve. But to get there, the surgeon has to make a big cut on your back. They have to tear your muscles, causes a lot of bleeding and scar tissue. And then once they get to the actual spine, they got to drill a hole in your spine. And when they take that hole and make the hole in your bone of your spine, they're also removing the ligament between the bones. So ligaments, can you imagine taking the ligaments out of your knee? What would happen if you started taking half the ligaments out of your knee? Your knee would go wobbly on you, and you would have a lot of pain and then arthritis, and eventually you would need another surgery done to your knee, okay, because of the instability that was created. Raytech on the floor. So the microdiscectomy procedure that's done all over the world for people with a pinched nerve is a horrible surgery. This is a much better surgery. We've got to stop doing microdiscectomies, okay? Microdiscectomy, look, let me explain something to you. In the history of medicine, doctors have come up with treatments, and over time we develop better treatments. It's a fact. It's not something I'm making up. And this that you're watching today is the better treatment that was created and discovered. Now, I didn't create endoscopic spine surgery, transforaminal surgery. There are other smarter, much smarter surgeons than me that figured it out. But I developed one thing, and that is the annular debridement. And that is the most important thing done in spine surgery today, because it eliminates pain. It eliminates back pain or neck pain or thoracic pain. And it eliminates leg and arm symptoms from inflammation. So until today, until now, the only thing done in the spine is decompression. All right, for those of you who have talked to spine surgeons, you know what I'm talking about. Decompression, decompression, decompression. That's all they talk about, decompression. What do neurosurgeons do? Decompression. And then once you've done your decompression, you've basically destroyed the normal spine, so now you got to stabilize it. So they call it stabilization. That's what fusion is, or artificial disc. But you don't need to stabilize the spine with fusion or artificial disc if you didn't destabilize it during surgery. That's a fact. And so the whole process of fusion and metal plates and screws and rods and cages and artificial disc is completely unnecessary now, because we're not destabilizing the spine. But why don't you know about this technology? The reason you don't know about it is because the companies that have been making these screws and rods and cages for all these years are going to go out of business. And it is $1 trillion a year, probably not trillion, worldwide trillion maybe, but it is $100 billion a year industry, easy. And so these companies like Johnson & Johnson, Medtronic, Sophomore Danik, these are medical device manufacturing companies. They're extremely powerful. They're not as powerful as insurance companies by any means, or banks, but they're very close. And they have tremendous sway. And the reason they're so powerful, watch the fluoro behind you, by the way. I think it's a little too close. Why don't you swing it? There you go. The reason they're so powerful is because their screws that they sell for fusion cost the hospitals and me, surgery center, when I do them, $1,000 a screw. All right, but they cost the company only a few dollars a screw to make, okay? They're going to argue, oh, it costs us lots more in research and development. Of course it does, but, you know, how many screws can you possibly make? You know, different screws. So, long story short, the cost of the implants is dirt cheap. The profits for these companies are massive, and they're not good for patients. Let's face it. If you could do this surgery instead of destroying the spine with a microdiscectomy, why wouldn't you do this surgery? You should. But the problem is people don't know about it, and the reason is because surgeons aren't being taught how to do this at the training centers anywhere in the world. Because the companies that sell the screws and rods are in the training centers. And they're controlling the education of the surgeons, the new generations of surgeons. Every year there's new surgeons trained. Every year there's surgeons released, new spine surgeons released worldwide, finished their training, completed 5, 6, 7 years of training in residency, after medical school, of course. And those doctors are trained to do fusions and artificial discs. They're basically trained to provide you, the patient, with what they've been taught by their leaders in the educational world of what is the best treatment, which is not the best treatment. It's a very expensive and damaging for you treatment, the patient. So I have gone and taught these surgeons at meetings with this Deuk laser disc repair. We have been peer reviewed and published, but the problem is we have also been, I'm not sure of the right word, but basically the people in control of educating at the universities have kept this technology from the surgeons that are learning, because there's no metal, there's no money to be made. It's an inexpensive surgery, relatively inexpensive compared to fusions, and there's no complications. We've had 0 complications in 1,350 patients now. 0 in 15 years. Not a single complication. That cannot be said for fusion. So, of course, the companies that sell the screws, rods, metal plates, and cages and artificial discs, they don't want you to know about this surgery because they're going to go out of business. And they're in bed with the surgeons and the faculty at the universities, okay? So that's why we educate the public directly with Deuk Spine Institute. We believe people should know. I don't believe it's right to subject people to pain and suffering as a result of a treatment that's antiquated, outdated, but it's not profitable for big businesses that control the world of spine surgery in the United States and therefore the rest of the world. So people need to know the truth. That's what my campaign is all about, is educating people about the truth. Look at this beautiful laser. It's removing the degenerated disc, which is the blue stuff, the herniated disc. It's cleaning out the scar tissue. This is all scar tissue here, all right, from an injury to this disc. Over there, that pink thing is the end plate of L4. Look at this. Now, when I put the dilator through the tear, it actually pushed herniated fragments into the disc itself, pushed it back from the neural foramen where the roots are, where they were interacting with the nerve roots in a way they shouldn't be, and it pushes them back into the disc. So now we're going to release these herniations and pull them out. And like I said, this disc in particular, most of the dye went to the front, so it didn't really come out the back because where I put the needle. Normally I like the needle to be about middle of the disc, but depending on this needle was kind of pressed up against the end plate at the bottom, so it really didn't get much dye to go in the back where I wanted it to go, but that's fine. It's not the end of the world, and I'm not going to redo it. It's not beneficial to the patient to take more time and redo the discogram and reposition the needle, because you could end up accidentally pulling the needle out of position. Look at that herniation there. So stand by, laser. So Flynn, how are things going?
They're going great.
Are you mastering the laser?
Yes, sir. Luis is teaching me well.
Luis is teaching you well, huh? I know that. Luis is a really good teacher. Have you learned how to do EMGs yet? They're right there. Ah, sterile processing. Great. All right. Well, we believe here at Deuk Spine in giving people opportunities to learn and better themselves in terms of their work. So, oh, that's a nice piece right there. Any questions, Diego?
Yes, somebody's interested. What is the brand of the metal rod that you use?
Which metal rod are you are you talking about? The endoscopic tube?
Yes.
Oh, it's not a rod, okay? It's a tube. There's a difference. A rod is solid, a tube is hollow. It's called a tubular retractor. I use Wolf, Richard Wolf out of Germany. This is all FDA approved. So when does the pump come in?
Huh?
The pump?
I expect it this week.
All right. We use Richard Wolf. There's other companies. Frankly, you know, I haven't used the other company's products. I've looked at them at meetings. I know there's one company in particular who follows my surgeries all the time called Joymax. And I've tried talking to them about working with them, but that's not ever panned out. eventually we'll have our own line of instruments as soon as Luis finds a manufacturer for me. Because we do more endoscopic surgery than anywhere else in the world except for perhaps Korea and the Wuridal Hospital. Now the endoscopic surgeries that they do are mostly lower back. They do a few necks. I do far more than they do in terms of cervical, and they don't do thoracic, but I do. So Deuk Spine Institute is the world leader in endoscopic spine surgery because we treat all areas of the spine, cervical, lumbar, and thoracic, and we've pioneered techniques in endoscopic surgery that nobody else in the world has ever done and that are beneficial to the patient in eliminating their symptoms, which they don't even probably know that I exist. And that's fine. That suits me just fine. They're my competition, and that's fine. You know, I don't need to be known to them. This is all dense scar tissue from tear and herniation. And once again, the blue stuff is the nucleus pulposus, and that's stained blue because it's degenerated nucleus pulposus. Degenerated nucleus pulposus is not normal. Normal nucleus pulposus doesn't stain blue. It's white. It doesn't bind to the dye that I use. It stays white. And we don't see white nucleus because we're not in a normal disc. We're in a degenerated disc. So the blue dye that I use binds to the degenerated nucleus because the degenerated nucleus is acidic. Acidic is the opposite of basic. There's in life, there's a balance between acid and base. They're opposite ends of the spectrum, and acids are molecules that release protons easily or readily, and bases are molecules that bind to protons. Protons are little atoms that are positively charged. Okay, protons. And so it turns out that organic life on Earth, anywhere in the world, or anywhere in the universe probably, requires proton concentration gradients and probably molecules that bind and release protons. So the nuclear material here is acidic, meaning it releases protons. And it has probably a free ionized negative charge group because it's a protein. It's not like bleach or hydrochloric acid, sulfuric acid. Those are inorganic acids. This is an organic acid, meaning that it's part of an organic molecule containing carbon, and the nuclear material binds to the blue dye and holds it, and therefore I can see the degenerated nuclear material and I can zap it out easily. Okay, anyway, it's that nuclear material that's blue that's been worked over by inflammation in this patient for a long time. Okay, so you don't get that blue staining unless there's been inflammation affecting the nucleus pulposus, and inflammation destroys tissues. That's what it does. It destroys things. So there's been a destructive force working on the nucleus pulposus over a long time here. And that destructive force is it's like bleach basically. It's a chemical milieu released by cells called polymorphonucleosides, or PMNs. Neutrophils is another name for them. And they come in and basophils, and they basically dump enzymes into the area of inflammation. And those enzymes are what are called proteases, lipases, and carbohydratases, like maltase, sucrase, etc. And they're stored inside the lysosomes of the cells and released in areas that the body wants to release them. And they're basically, it's like chemical warfare going on here. That's what inflammation is. It's chemical warfare going on in your body. And your body is attempting to eliminate the foreign invaders. Okay? So it's like an invasion of a foreign force, something foreign to your body. That's the nucleus pulposus. Your body recognizes it as foreign because it's been hiding in a cave in your body your whole life, inside the middle of your disc, until you release it and open the cave, you know? Okay, when you release it and open the cave, the nucleus comes out. How do you open the cave? That's the annular tear. When the annular tear occurs from trauma, it allows the nucleus to squeeze out to the world and blink its eyes in the sunlight. And then as soon as it's done blinking its eyes, your inflammatory system goes, holy shit, look at this thing. Attack! And your blood vessels dilate, your capillaries become leaky, they allow cells to migrate, first of all to marginate, which means to bind the wall, internal wall of the capillary, the endothelium, and then to migrate across and into the tissue, where they basically are like soldiers arriving by helicopter or by boat, and they just start attacking everything with chemical warfare. And unfortunately, that chemical warfare results in damage to normal structures like the rest of your annulus and the nuclear material that's not even herniated. It's just in the middle of your disc. But all that inflammation releases so much chemicals in the area that innocent women and children are attacked by the chemicals, aka the normal disc is destroyed by the chemicals. And people go, I don't understand what causes degenerate disc. All these dummies haven't figured it out in 200, 300 years, and I have to sit here and figure it out in private practice for them. It's really irritating. You know, there's lots of things like that in life people haven't figured out. Like, what do we do with our prisoners, you know? How do we stop world hunger? How do we stop cholera? How do you stop cholera? For God's sakes, cholera. It's basically infection of your drinking water supply. And yet cholera kills more people around the world than any other disease, any other condition. Dehydration. People die of dehydration. They just poop water out all day long until they're dead. And they keep drinking the cholera water that they have, infected with this cholera, which is a parasite. Right? So is it irritating to me? Yes. You got billionaires like Bill Gates and Mark Zuckerberg and Jeff Bezos, who could literally, we could cure back pain, we could cure neck pain, we could cure coral disease that's killing all the corals in the ocean. We know why they're dying now. I figured that out in my free time, in my lab. I had to do that in my free time, and I haven't even gotten any money for it. Okay, I did it just because of my passion to solve problems for the world. I've even figured out what to do with prisoners, but you're not going to want to hear me talk about it because it's going to upset some people. But there's a way to solve crime. And, well, all the big problems in society, whether it's famine or whether it's disease, there's solutions. But for some reason, we're not achieving those solutions. We're not trying. So I can only do so much. But one thing I can do is make you all aware that there's a way to cure back and neck pain. There's a way to fix herniated disc, bulging disc without fusing, without invasive surgery like artificial disc surgery going through the belly, doing damage to your body. There's the end plate, by the way, that I was talking about. We are in the tear. The tear was really running along the end plate. I don't know if you noticed that, but it was all the blue stuff was kind of like right here. So it was a separation of the annulus fibrosis, and you can see the blue stuff inside these outer annular fibers. And that blue stuff is, like I said, it's nucleus pulposus. You cannot stain the annulus fibrosis with the blue dye. So the blue dye stains nothing but degenerated nucleus pulposus, the stuff that's supposed to be in the middle of your disc, okay? So clearly the fact there's blue here interwoven between the annular fibers tells us that there's nuclear material from the herniation still in there. And you can see all the scar tissue, the golden whitey stuff down here. It's thick and not gelatinous, but it's thick. It's collagenous is the right word. And the golden color is calcium deposit. So basically, this is another injured disc. We call them herniations or bulging discs. And they're a result of the tear, the annular tear that happens in the back of the disc. And then pressure on the disc from normal activities like bending, lifting, twisting, working out, playing a sport, whatever. And you squeeze that jelly out through the tear. And that causes the inflammation to start. And Diego, we've shown the causes of back pain video.
Yes, and the comparison.
Why don't we show the causes of back pain video one more time for those people
Yes.
who've been watching and maybe haven't seen it.
Yes.
Can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. Inflammatory tissues develop within the annular tear, causing back pain. The inflamed annular tear generates pain signals. Additional injuries can cause symptoms to worsen. Inflammation from the annular tear can spread to nearby nerve roots, causing leg pain. Signals travel up nerves to the brain, causing localized back pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of pain. If you have a herniated or bulging disc and back pain, submit your MRI for
You're alive.
All right. Well, we're done here with this disc. And we've just finished repairing it with the laser. The Deuk laser disc repair, again, named after Deuk Spine Institute, where the procedure was discovered and performed first. Let's have the dilator. Don't let that laser fiber go anywhere. All right. We're going to do a little irrigating with some antibiotics. That all you got is, we don't have a needle. So we're going to irrigate with, sorry, not antibiotic, but I guess it is antibiotic, antiseptic. We call it benzoin, not benzoin, I apologize, betadine. It's developed by NASA, which is, NASA's very close to where we are, literally 10, 15 minutes away. Depends on how fast you drive. But we used to watch the space shuttle launches here from our building. And we still see rockets get launched. This is SpaceX nowadays. Blue Origin with, I think it's called the Good Shepherd, I'm not sure. Huh? New Shepherd. Not the Good Shepherd. The Good Shepherd is someone else, right? But long story short, we are in the Space Coast of Florida. That's where Deuk Spine is originated. And we're treating patients here at our facility on the Space Coast, right next to SpaceX and Blue Origin and the New Shepard and the old NASA and all the satellites that get launched all the time, right? Whether they're military satellites or commercial, civilian satellites. All right, so we finished the L4-5 left approach. What we found was that, yes, there was a tear. There was a herniation through the tear. The tear was low-lying. It was along the bottom of the disc. You want to put your hand here?
Yes, sir.
And The tear was, it was not a huge tear. It was a small tear, but it was still causing inflammation and pain and pressure on the nerve root. So we cleaned it up, and that should take care of that one. Now the next two discs we're fixing are definitely worse. The tears are bigger. The pain is worse from those discs. We tested them at the beginning of the surgery, and they're causing 10 out of 10, 10 over 10 pain. That is the typical pain the patient has every day. And she has back pain every day. It's hurting her tremendously. It's like everybody else's chronic back pain, and it comes from those disc herniations. So she didn't want a fusion. She didn't want artificial discs. She didn't want invasive surgery. She wanted laser surgery. And that's why she came here, like many people from around the world, because they don't want the surgeries that are being offered to them because they're far too invasive and unnecessarily invasive. Shot. Now, just for the record, so you understand a little more about me, Dr. Deukmedjian, the founder, I started my surgical career as a neurosurgeon doing fusions and artificial discs, okay? And I've done thousands and thousands of fused discs. And I've done laser surgery alongside. So during my career, I've done both, okay? And as I've watched the results of laser surgery surpass and far exceed the results of fusion and artificial disc, it becomes very difficult for me to even recommend fusion to anyone at all. And becomes impossible to recommend laminectomy and microdiscectomy. I don't recommend those anymore, okay? That would be like recommending, dropping a bomb on a country that you're not happy with rather than trying to negotiate, through negotiations and meetings and compromises and agreements, okay? So you don't just go and drop nuclear bombs anymore. They're too damaging and too devastating. Sure, they get the point across. Sure, they're very effective. But it's immoral, it's irreprehensible, it's unconscionable to do that, okay? I am not a believer in using force to, lethal force to have a political agenda. So I think most people would agree that nuclear bombs and war are really bad, and they should be reserved only in the most extreme cases. And that's how I feel about microdiscectomies and laminectomies now. Now that I've done over 1,000 of these endoscopic surgeries, 1,000 patients. We've done 1,350 patients now. And that's not a lot. There are certainly endoscopic surgeons that have done more than me. But I do them in all parts of the spine, cervical, thoracic, and lumbar. And the endoscopic surgeons that have done more than me have only done really lumbar, okay? Which is what we're doing today, obviously. But I cannot, in good conscience, recommend surgeries like laminectomy, microdiscectomy, fusions anymore, artificial discs anymore, because this is so much better for the patient in every way. The results are better, like the elimination of pain is better. We have about a 98% on average elimination of back pain, 98% of the back pain, and elimination of leg symptoms, numbness, tingling, weakness, and pain. So you can't get that with open surgeries like artificial discs. They don't have that high of a pain elimination, okay? You can't get that with fusion. I mean, I can, but nobody else can. And then, of course, the recovery for this is like 1 day, and the pain is usually gone after a day, okay? Compared to fusion surgery or laminectomy, where you're going to have pain for weeks and months, maybe even longer. Shot. Making slow progress at L5-S1, that's fine. Let me see if it's embedded enough. It's probably good. Go ahead and pull the guide wire. Shot. I felt that sliding through the tear. and I had to make it noteworthy. Did somebody get that joke? That was a high-level joke. Did you like the notes? My musical notes? Huh? You like that for good measure? Ah, another one, huh?
We have a few questions when you're ready, doctor.
Phew, we got a long way to go. Look at that. The reason why I'm having to use the mallet is that this patient's iliac crest is very high, and of course we're passing that bone, and that's the reason why. So just to review, endoscopic spine surgery, the kind that I'm doing called transforaminal. It's done by only a handful of spine surgeons in the world. Only a few of us know how to do it and have the equipment to do it and training. But the ones that do it for the lower back, they don't do it at L5-S1. They never do it at L5-S1. I'm the only one who does it at L5-S1 because it's too difficult for them. Technically, they can't do it. They don't have the experience. They don't have the right equipment. They don't have the right, they don't have the know-how. So what they all do is they'll do, 2, 3, 3, 4, 4, 5 transforaminal, but when it comes to 5-1, they do a translaminar. They basically go in and remove the ligaments and bones of your spine, just like a laminectomy. So it's very bad. But they do that because they're not able to do what I'm doing right now, which is very difficult to do, by the way. But I've done so many of these now that I've gotten it down pretty good. Long story short, you don't want a translaminar endoscopic procedure because that procedure is very damaging to your spine at L5-S1. So be careful. If you need L5-S1 surgery and you're talking to an endoscopic surgeon, make sure that endoscopic surgeon is going to not remove your bones and ligaments from your spine. All right, I'll take the question.
Okay,
Just about
doctor.
there.
We have somebody from YouTube who is scheduled to have a cervical fusion.
Don't do it.
They just found your practice and really wants the surgery, but is afraid that the surgical center is out of network. They're currently with United Healthcare.
Yeah, so somebody is set to have a cervical fusion, and they found this surgery and they want to have it done, the endoscopic surgery. By the way, we're doing 2 cervical endoscopic surgeries next after this case, right? We're doing, I think, a 2-level and a 1-level. So before you decide anything, watch the next 2 surgeries today because they're amazing. You're going to be blown away at the surgery. There's no big incision. There's no bleeding. There's no scar tissue. It's done with a 4-millimeter incision, and you don't need the fusion. And you want to know, is my insurance going to cover it? Well, that's a great question. We are at a network with United Healthcare, but is your health important enough to you to get the right surgery done for yourself, or do you want to get butchered because that's what your insurance company is going to pay for? Yes, I'm being blunt about it. You're right. I've done over 1,000 anterior cervical discectomy infusions, and I do them very, very well, but they're still extremely invasive and damaging to the patient's body. And why do surgeons do it? Because that's all they know how to do, those and artificial discs. So why should you pay a price and suffer with scar tissue, trouble swallowing, hoarseness, complications from the metal and screws? Why should you have to subject yourself to that just because your insurance, you're worried your insurance won't pay? So some people just cannot, pay for the out-of-network facility, and other people can. If you can, I strongly recommend you consider it. I can't tell you how many people have had bad outcomes from cervical fusions. It's all over the internet, if you don't believe me. But we've had 0 bad outcomes with the laser surgery. But, ultimately, people have to make a choice for themselves. Do they want to let their insurance company decide, or do they want to take control of their life and do what's best for themselves? We've done over 500 cervical endoscopic surgeries, 500. I've done 500 in 16 years, 15 and a half years now. And not a single one of those patients would go and have a fusion if they had to redo it. And they've all had elimination of their pain, and they're very happy. Now, the reality is that the disc herniation causes a lot of symptoms like neck pain, headaches, arm symptoms. But there's another condition called facet syndrome where you get arthritis in the facet joints. And that facet syndrome is not fixed typically with the Deuk laser disc repair because we're only fixing the disc, not the facet joints. So I could see someone who has really bad facet disease and fails to get better with what's called a rhizotomy, when it's done properly. I could see somebody like that wanting to get a fusion. But I would reserve fusions for very restricted cases. Very, very restricted cases where there's impossible to do the laser surgery. Anyway, you make up your own mind. The whole point of doing these surgeries is so that you can learn the truth. And at the end of the day, each person has to decide for themselves what's best. But what I believe in is something called the informed consent. And informed consent just means, simply put, that the patient who's about to have treatment is informed of all the benefits of each treatment and the risks of each treatment. So the potential benefits and potential risks of every treatment they're doing. And that's what my goal in life is to help people become informed about the truth. So yes, the facility is out of network with United Healthcare. That is the truth. But the reality is you're going to get the best surgery in the world here. And the reason we're out of network with United is that United Healthcare just doesn't want to pay for people to have good surgery. The reality is that they want to restrict access to the best care and the best technology. It's counterintuitive, but after dealing with insurance companies for myself for the last 25 years, I know how they work. Their game is to restrict access to good quality care. It's to scare patients into doing what they want you to do. So think about it. If United Healthcare, for example, and by the way, United Healthcare does pay for the surgery. We've had payments from them, okay? But United Healthcare is an insurance company that makes billions of dollars every quarter in profit, billions, about $2.5 billion on average a quarter in profit because they are denying medical care to people who need it. And it's not just endoscopic laser surgery, it's everything. United Healthcare, Blue Cross Blue Shield, Cigna, pick your insurance company, even Medicare. They're in the business of denying treatments and tests. Have you ever had something denied? Have you ever had your doctor say to you, hey, there's this great new medication, it's got fewer side effects and it's safer for you. I want you to have it for your diabetes. And then the insurance company says, sorry, we don't cover that new medication. Well, why? It's all about money, folks. It's nothing else but money. Okay? Insurance companies make decisions about money, and it's all about how can we make more money? The insurance company, that's how they think about your care. And will you accept a denial? So you can fight your insurance carrier. If you have out-of-network benefits, if you've paid extra money for premiums to get out-of-network benefits, then you have the ability to come and get your surgery paid for out-of-network. And I got more news for you. Let's say your insurance doesn't cover at the surgery center. Okay, it's out-of-network. You could argue that there's nowhere else you can get the surgery done but here. And so they have to provide you with an in-network physician that does this Deuk laser disc repair. Okay? So for those of you who want to just be victims, then go with what your insurance company tells you and just live with it, you know? but you're never going to get the best care. And for those of you who believe you deserve the best care and that you've been paying for the best care and that you want the best results for yourself, then pay for it and fight your insurance company with us. And we'll kick them in the ass. That I can promise you. We've got great lawyers. And yes, it's unfortunate, but the truth is that if you want your medical bills or your bills paid with insurance companies, you got to fight them. Why do you think Morgan & Morgan exists? If you live in Florida, you know who Morgan & Morgan is. They're the biggest personal injury law firm in the country. Okay? They have like 500 lawyers, and all they do is fight insurance companies to get payments for damages that people get from car accidents. Okay? I'm not an advocate of Morgan & Morgan. I'm just using them as an example. But if you think your insurance company is so good and pays for all the things you need, then why are there lawyers, personal injury lawyers? Personal injury lawyers exist for one purpose, because insurance companies don't pay their bills, and they don't pay fairly. So if you want to let that situation rule your world, then go for it. I can't convince you otherwise. You're set. But you know, at least you've been informed of the truth, and then you make an educated decision. And that's all I can ask. I just want people to be aware that there's better treatments out there for their problem in their spine, and that they don't have to just go with what their doctor tells them, which is a worse treatment like fusion or artificial disc, or do nothing, that there's better treatments. So ultimately, you know, people have to decide for themselves what they want. All right, what other questions, Diego?
Yes, we have a person on YouTube who says, "Hey doctor, I've been watching you for some time. I'm 22 and my back is extremely in trouble. For the last 5 years I've been working out and has been getting pain every day. What do you suggest?"
So this is somebody who's having back pain every day. They've been, you know, exercising, taking care of themselves, trying to stay fit, but they're still having pain. I would say you need an MRI to figure out why you're having pain. Now, going along with the whole insurance discussion, you're probably going to have a denial from your insurance carrier. They don't want to pay for your MRI. Anybody know why the insurance companies don't want to pay for the MRI? Simply put, they don't want surgery being done. You can't do spine surgery unless there's an MRI. So they've learned that, hey, if we deny the MRI, then there won't even be a surgery recommendation. What the insurance company wants you to do is just like the Nazis did with the Jews during World War II. They want you to go along peacefully to the gas chamber, all right? Except they want to keep you alive because they want your premium payments, but they don't want to actually give you any food or shelter. They don't want to respect you. They don't want to treat you like a human being. They just want to kill your need for medical care. I'm sorry I had to use that example, but it makes me so angry because I really feel like people's lives are being destroyed by the insurance companies' unwillingness to do what they're supposed to do, which is to pay for your medically necessary care. And yet they're not. And nobody's really standing up to it. And it's just so upsetting. So I'm sharing my frustration with you about insurance companies. They are your enemy. They are not your friend. And the money that they make every year in profits is only a small fraction of their real profits. They are diverting money and profits overseas to where you cannot and the government cannot monitor it. Okay? Because they don't want to pay taxes on that extra profits. And they don't want to give that profit to the shareholders. So if you're a shareholder, demand an investigation, an accounting. How? How are they doing it? They're using subsidiary companies, okay, that are not in the insurance business but are service industries to the insurance business. And they're basically funneling profits into those companies that the big dogs own, okay? And meantime, people are getting screwed out of their health benefits. So I have no problem with companies making profits as long as they make them honestly. And insurance companies are the most dishonest, aside from banks. They're the most dishonest, and politicians, the most dishonest entities. I need my laser on. So what do? You need an MRI, okay? Get the MRI done. and then send your MRI to us, send the CD to us, send the report to us. We'll look at it, and I will personally review it and tell you what you need done to fix your back pain. By the way, for those of you who don't know, we do offer free MRI review services at Deuk Spine. What's bleeding, by the way, is the end plate. It's called the end plate. That's the S1 end plate right there. It's not the actual herniation itself, but it's the bone below the herniation. We call it the end plate. It's part of the vertebral body. Why is it bleeding? Because I traumatized it a little bit during the surgery. It's inflamed from all this inflammation going on, so it's very red and inflamed. And I started to remove the herniation next to it, and it's not happy with me. But it is going to make your viewing of this disc treatment harder to see, but fortunately I've done thousands and thousands of these things now, these disc repairs, because each patient I do has an average of 2.5 discs. So if you think about it, I've done 1,350 patients with an average of 2.5 discs per patient. So I've done a lot of disc repairs in the last 15, 16 years. So I'm used to not being able to see very well. It's kind of like flying a jet plane with instruments, you know, rather than your eyes. You still can do it, but you have to rely on other pieces of information to navigate properly. So go ahead and send your MRI in to mri.deukspine.com. Can you put the link up there for the audience? Anybody that wants to send an MRI of their back or neck in, we're happy to look at it, review it, and give you our opinion. Any other questions?
Yes, we have another question. Well, to continue with the previous question, they said that they have been going to physical therapy and been trying medication, but nothing helps. It's hard to sleep for them, and they can't stand for more than 45 minutes straight.
Yeah, you know, I don't know what's going on for sure, but if you're having back pain with standing and walking or moving or whatever, any kind of back pain, it's either going to be a fracture, a tumor, an infection, a disc herniation, or facet pain. You know, it could also be the sacroiliac joints or the piriformis muscles, okay? So it's a limited number of possibilities. It's not an aneurysm in your aorta. It's not a, you know, probably not a kidney stone. It sounds mechanical in nature, meaning, you know, spine related. And, you know, if you took 100 people out on the street with back pain, about 80% plus are going to have herniated disc as the cause of their back pain. Herniated or bulging disc, okay? So that's just as playing the odds, that's the most likely reason you have a problem. But you won't know that unless you get an MRI or a CAT scan. These x-rays are not really good. They're good at looking for fractures or malalignment, but they're not good at looking for herniated disc. So you need an MRI. All right, I call these fumaroles. They're kind of a pain. But they're part of dealing with herniated disc surgery. Stand by. See the grabber?
We have a question from Facebook.
Sure.
If the patient can't achieve union, would you debride the joint of debris or just leave it as a non-union?
All right, so someone's asking a question about fusion surgery, and they're talking about what surgeons do where we try to fuse two bones that are not normally together. We're trying to fuse them together, okay, so they become one bone. And when they become the one bone, wherever they become, it's called a union. All right, so the person's asking a question about, all right, well, if you're supposed to have a fusion between two bones and the bones don't fuse, so there's no union, can you treat that non-union with the laser surgery and debride the non-union? The answer is yes and no. I've done laser surgery on people who have not fused, and it's worked. But it only works if they're still having pain at that level that didn't fuse. Okay? And this is kind of the surprise. Maybe some people don't know this, but just because your bones didn't fuse doesn't mean that's the cause of your pain. As a matter of fact, non-unions of spinal fusion rarely cause pain. Rarely. So by far, the most common cause of pain in a non-union scenario is that there's another disc injury. This damn end plate's killing me. So there's another disc injury above or below the non-union. Does that make sense? And that's probably what you're dealing with. Grab her. So don't assume your pain is coming from the non-union, because that would be a mistake. A really big mistake to make. I see that mistake all the time. People make that mistake all the time. Non-unions rarely ever cause pain. Unless, like, the screws are really loose in the bone. I mean, if you have really loose screws, then yes, you could have non-union pain. But I got to be honest, I've seen probably 1,000 patients with non-union in my career. Not my surgeries, of course, but other surgeons' patients. 1,000 easy. And of those 1,000 patients with non-union, how many had pain from the non-union? Probably 5 at most, 5. So think about that. That's a very low percentage of people with non-union that end up needing to be refused to get rid of their pain. Like I said, the vast majority of people with pain after a fusion, that pain is coming from an adjacent disc above or below that non-union, or facet joints, or the piriformis muscle if it's in the lower back, or something like an infection, which is extremely rare, by the way, very rare, thank God, or fracture. So you really need a thorough assessment to figure out the cause of your pain. I can tell you that many surgeons don't know how to find the source of pain. And so they end up treating patients with treatments that don't work because the actual source of pain has never been discovered. And the surgeon's treating what they think is the source of pain when it's actually not the source of pain. So, thanks. Hold on. Again, we're getting to the end of this disc, and just a little more to go. You can see the fat herniating at 12 o'clock. That's just the epidural fat. There's nothing to be concerned about there. I usually just zap it because it's blocking my ability to finish the disc repair, and patients never complain about having less fat after surgery. That was supposed to be funny, but nobody's laughing today. I think, did somebody die that I don't know about? Thank you, Luis. Hey, Diego, can you let Deb know that I'm going to be ready for some fresh coffee soon?
Sure, I'll pass that message on to her.
Huh? You'll pass it on? Good. Thank you. Looks good. I want to get the back side. We're just about done with L5-S1. I'm very happy with the progress we're making, but I'm not happy with the the redness of the fluid, which is really insubstantial bleeding, inconsequential, minor, nothing. We've probably lost maybe 20 drops of blood, maybe a milliliter so far, but certainly not more. And all it's done is try to make my life more difficult, right? It's like my employees sometimes. They just want to make my life more difficult. I just call it selfish bleeding. You like that? Selfish bleeding? All right. Okie dokie, artichoke. Let's get that betadine, the stuff that NASA developed. All right, let's have that. Yeah. We've done 2 discs. We've repaired 2. We're getting ready to finish up with number L3-4. Maybe a little more irrigation. Thank you, Luis. So we used to use, a long time ago, with our irrigation, we used to use bacitracin, thank you. I'm thinking about something else. But bacitracin. We used to put bacitracin, it was an antibiotic, in the irrigation. And then, then stupidity occurred among medical professionals. And the FDA warned that intramuscular injections of bacitracin were neurotoxic, which nobody ever did really intramuscular, but some stupid people. And I don't know why they ever chose to do that. But anyway, it ruined it for everybody because bacitracin was inexpensive, dirt cheap, and it was very effective at killing gram-positive bacteria. Now, the most common cause of infections from spine surgery are gram-positive bacteria. So, pressure. It was wonderful using bacitracin because it was cheap. You could put it in the irrigation. It was water soluble. Like a lot of antibiotics are not. Pressure. More pressure. And it was very effective at preventing infections. But now it's impossible to get it because of the reported complications from intramuscular injection, which we don't do an intramuscular injection once again. But. Okay, we're going to move on to our last. So we have to use betadine, developed by NASA, which is very effective. Relax a little bit. It's very effective at killing bacteria, fungi, I imagine viruses, though I don't know for sure. The 3 primary pathogens, and of course there are amoeba, not amoeba, but parasites as well. But you know, parasites aren't really a kind of infection that people get when they go get surgery. You get bacteria infections or fungal infections, and by far the most common is bacteria. All right, that's our picture there shot. Good, we got our guide wire in. I'm going to pull the needle out. Now this disc here, L3-4, was very painful for her. It was a 10 out of 10 pain. No, 11 out of 10, sorry. Oh, this was 10. The L5-S1 was 11. So there's a huge tear here. I could see it on the x-ray picture once I injected the dye in the discogram. And, yeah, let me see. Anytime we have bleeding that is in the muscle, shot. Okay. Where's my... Anytime we have any bleeding that goes in the muscle, it doesn't, unless it gets to be really big, it's not a problem, like a safety issue. And if it gets really big, it could be a safety issue. All right, that's why we make sure all of our patients they're off blood thinners, they're off anti-inflammatories, they're off the like ginkgo biloba and fish oil and turmeric. Okay, mallet. They're off all those supplements that cause bleeding. Shot. So we stop supplements, we stop, move your hand. We stop anti-inflammatories, and we stop blood thinners and antiplatelet drugs. Okay? And by doing that, we minimize the amount of bleeding shot that the patients have. Okay? Shot. Hold that. Shot. Shot. So if you do this kind of surgery and you go past through the muscle, the bleeding usually comes from the epidural veins, okay, which are the little veins around the nerves in the spine. Or it comes from a vein in the muscle. So either way, you put a little bit of pressure. As long as it's venous bleeding, it's low pressure bleeding. It's 10 millimeters of mercury. It won't create an epidural hematoma or an intramuscular hematoma. The only kind of bleeding that would do that would be arterial bleeding. And, you know, we're not anywhere near arteries. There is a foraminal artery, but where we typically operate, it's not very big. It's small, and it's really hard to get hit and tear, so pretty safe. Shot. All right, we're making pretty good progress here. We're once again at the L3-4 disc. This is one of the discs we're fixing because it's herniated, torn, and causing horrible pain. Shot. And so we want to repair it. And that's what we're going to do. Any other questions?
No, just some praise. People saying you're doing a good job. That one person who was having back troubles said that they got their MRI yesterday and will submit it as soon as they get the results.
All right, good. So just so people know, we are here to help anybody we can, as much as we can, and hopefully without charging as much as we can. But basically, the things that I can do for the community of the world for free is any kind of advice I can give, and looking at your MRI, we do that for free and let you know what's wrong and what's likely contributing to your symptoms or causing your symptoms. But, you know, the reality is that you can't make surgical decisions based on just an MRI. You have to actually see the patient and do what's called a physical exam. And nowadays, these exams, they're able to do them over the internet through Zoom or Skype. And if I can just see somebody and where their pain is, they can point to it and kind of show me where it runs, then I can combine that history and physical with the MRI or CT, and I can usually figure out pretty quickly what the cause of the pain is, okay? So if you're interested, we offer that for free. There's no charge, literally no obligation. You just have to upload your MRI images through the internet or send us your MRI CD. And that way we can upload it and I can look at it. It just, the process is pretty quick, and you get a free opinion from a neurosurgeon who literally just does spine surgery all day long when I'm operating. I do brain surgeries if I need to, but rarely. I mostly just do spine nowadays, which I like because we're able to help people get out of pain, which is special. And someone needs to do it. But we're happy to meet you and look at your pain and look at your MRI and tell you what we think is wrong, whether or not you treat with us. We don't expect everybody to treat with us. We expect most people not to treat with us, but we still offer the service for free because, again, we want to help people avoid unnecessary treatments that don't work, that could hurt them. We want to make sure people do informed consent to whatever treatment they choose. Whether it's with us, with some other doctor, it's fine. Just as long as they're aware of their choices and the potential risks and potential benefits. So if you're interested to find out more, if you want a personal face-to-face interview with me to talk about what's wrong and what the risks are of each treatment, what the potential benefits are, I'm happy to do it. You're welcome to also post questions here during our live surgeries. We have 5 surgeries today. We have patients from all over the world coming here for these surgeries, these endoscopic laser surgery, because they can't get it done anywhere else. So I'm happy to take questions during surgery and answer them. The surgery part that I do right now is pretty standardized and straightforward. I don't really have much variation. It's not like taking a brain tumor out, but even if I was taking a brain tumor out, I could still talk to you. Honestly, when you get really comfortable and you understand what you're doing and you know how to do it really well, talking and telling jokes, listening to music, whatever it is you want to do while you're operating, we all do it. Don't be surprised if you were to go into any operating room in the country or world, whatever the surgery is, there's going to be people talking most of the time. There's going to be people listening to music, and that's normal, okay? But instead of talking just to my staff or my colleagues, I talk to you. Why? Because my goal is to answer your questions and help you out. And I'm not doing anything else. I guess I could watch a movie, right? But no, seriously, it's easy to talk and answer questions while I'm operating. So I figure why not use this time to teach people more about the spine and anything to do with spine, basically. I'm happy to talk about. If you want to talk about coral reefs, I'll talk about coral reefs. I just don't talk politics. Don't have any interest to. And I'm happy to help out. So if you haven't figured it out yet, we do have a Deuk Spine Institute app that you can download for free. And it's got a lot of great information. And Zach is actually working on updating the app. We're going to come out with an update. So the new update is going to make it easier for us to make changes and more updates. Currently, with the way we do the app, if we want to update the app, it's a kind of a pain in the butt. We got to go back to Apple, and we have to have them review any updates we do, and it's a process. So now we're going to be able to do updates easier without going through a bunch of bureaucratic tape. But the app, you're going to see some changes for those of you that have downloaded it. We actually use the Deuk Spine Institute app every day in clinic, and the way we use it is quite unique. When patients come in and they have a medical problem, we find out what their diagnosis is, we figure it out in clinic, and then we actually log it onto your phone on our app. And so you can actually leave the clinic and you can go, and while you're sitting waiting somewhere for something to do something, you can pull up the app and look at your diagnoses and read about them. We have sections in the app that explain herniated disc, what it is, bulging disc, radiculopathy, spinal stenosis, pinched nerves. And so there's really good information in the app. It's like a library where you can go and learn more about the condition. And then we also have our treatments loaded in there. Whether there are proprietary treatments like the surgery you're watching now, the Deuk laser disc repair, or there are treatments available around the world like rhizotomies and muscle injections and trigger points and things like that. They're all in there. So you can get information off the app. You can also go to our website, deukspine.com, and we have a lot of really good information on the website. And we're in the process of working on our Roku channel still, building content for it. That should launch probably in the next 2 or 3 months, we're expecting. In the meantime, we're going to continue to do broadcast of surgery, like we're doing now every week that we do surgery. We make it available for the public to watch spine surgery live. We're the only place in the world that broadcasts live spine surgery, to my knowledge. And we've been doing these live spine surgery broadcasts now for 7 years on YouTube, Facebook, Twitter, Periscope, and LinkedIn. Well, Periscope is Twitter, but YouTube, Facebook, LinkedIn, and Periscope, which is the Twitter platform. That way people can watch surgery. You can get questions logged in and I can answer them, and we can teach you as much as we can, as much as you want to learn. But you're not going to find this information elsewhere. You're not going to get this from your chiropractor. You're not going to get it from your physical therapist. You're not going to get it from your primary care doctor. You're not going to get it from your orthopedic or neurospine surgeon, because they don't know anything about most of these topics. They really don't. Yep. So if you want to know where the truth is, this is it. We'll give you the truth. Any questions?
No, but that same person says they will download the app, and thank you for the resource.
Oh, nice. We are almost done. We have about 5 minutes left. A little bit of inflammatory tissue there. That was a little nest of granulation tissue I just zapped right there. We have Deb making coffee. All right, so Luis, next 2 cases are cervical. You're going to change the room? All right. So we're going to do 2 cervical spine surgeries. One of our patients, the next one, has 2 herniated discs. We're going to go through the front and repair them without fusing or artificial discs. It's more advanced. It's the endoscopic Deuk laser disc repair. For those of you wondering, the Deuk laser disc repair has already been peer-reviewed and published in the National Library of Medicine back in 2012, 2013. We published our results. Our results have gotten even better since then, but the surgery has been peer-reviewed and published in Surgical Neurology International. This is an open access medical journal. They don't charge you money to read the articles, which is why I chose them. They're a top neurosurgery journal for neurosurgical discoveries in the field of neurosurgery, and they are very reputable, and they're free. So unfortunately, most medical journal publications are not free. You have to pay. You have to pay like $100 or $150 for an article to get a copy. But I wanted an article that everyone would have easy access to and wouldn't be charged for it. So I went with Surgical Neurology because they're progressive and open access for the public to read the articles. Anyway, you can go to PubMed and type in Deuk laser disc repair. You'll see some of our publications. You'll also see that I've published infusion surgery techniques like transforaminal lumbar inner body fusion. There's the tear. We've been following this tear at this disc. A lot of degenerated nuclear material here that we're going to clear out the laser. For those of you who don't know, the blue thing is the laser, and it's really just a plastic coating over the laser fiber. The laser fiber itself is made out of glass, and the glass transmits laser energy from a machine that's here in the operating room. It's about 5 feet away from me, and it transmits the energy from that machine that produces it, the laser beam. It transmits it to the end of this glass fiber, and I basically apply the laser energy to tissue. We call it tissue modulation, and the laser modulates tissue by breaking up covalent bonds between proteins. So it basically delivers a wave of energy to the disc herniation and the annular tear and annihilates it. So there's a destructive force. But surgery really is about, when you use a scalpel or surgical instruments, you're destroying. You're not creating. And then we will close up things. Sometimes we add metal or plastic to reinforce tissues. But for the most part, surgery is about excision. Excision means to remove, and remove means destruction. So this surgery, we're destroying the bad tissue, the tissue causing pain, with the laser. All of this is scar tissue, and it almost looks like this patient had an epidural injection. It's quite likely. This is all scar tissue from the inflammation. This is not normal, shouldn't be here. This is all related to the annular tear. And this part of the herniation looks like it's been around for a while. I would say years, at least 4 or 5 years. And I don't know the exact age, but this part here is definitely fresher, newer. So like most disc herniations, it's not a one-time event. It's a multiple incidences that ultimately culminate in, constant pain that the patient has to deal with because the repeated injuries to the disc, and they never quite heal properly. Of course, our fumarole is now back. Anybody know about the fumaroles? Yeah, they're in the ocean, the deep sea. And why are fumaroles so important? That's pretty good, anaerobic bacteria. You're right. Fumaroles are important because they've taught us that there is one place on Earth where life can exist without sunlight, without the energy of sunlight. All life on Earth is driven by sunlight except for life around a fumarole, a deep sea vent, where there's actually lots of microorganisms and macroorganisms that live in a community that is completely independent of sunlight. So if the sun were to vanish tomorrow, all life on the surface of the Earth would cease to exist, obviously, but we've now developed artificial sunlight. But without the artificial sunlight, all life on Earth would cease to exist. Still would, because the Earth would get very cold. But the fumaroles could support life. And the reason is that hydrogen sulfide is released at the vents. And hydrogen sulfide happens to be a very energy-rich compound. And so the organisms living near the thermal vents at the bottom of the ocean can take that energy from the hydrogen sulfide. It has very reduced electrons that are full of energy, and they can process that hydrogen sulfide. And just like we have what's called an electron transport chain in our mitochondria that generates ATP, AMP, cyclic ATP, all these energy intermediates, NADH2, FADH. We use those intermediates that store energy for cellular activities to keep us alive. So the organisms down at the thermal vents, they don't use the electron transport chain the way we do, which we use glucose to power ours. They actually use hydrogen sulfide to power theirs, which is released from the thermal vents from basically magma, lava, all that stuff down there. Pretty cool. All right, we are just about done. Let me see the grabber. Probably need to get a little more right there at 12 o'clock. Looks like there's still some inflamed tissue that needs to go bye-bye in order to fix this patient's pain. So I'll work on that. And again, there's bleeding, very minimal, but this bleeding is a result of inflammation in this area. The thing about inflammation is it has really 4 qualities or characteristics. That it has swelling, it has redness, it has pain or tenderness, and it's warm, thermally warm. And the reason for the redness is increased blood flow to that area, because remember, blood is red, so you get more blood flow, you get red. And then the warmth obviously comes from increased blood flow, right? Because blood is warm. So the increased blood flow of inflammation to that local area is what drives the temperature, the higher temperature of inflamed tissue, the color, the redness. And of course, it also causes edema. Edema is a movement of fluid outside the blood vessels into the surrounding tissues. And it's that edema then that causes the sensitivity of the nerves. Plus there's substance P released and all kinds of stuff. All right, we're done here. Let me just see. That looks good. Sorry for the poor visibility. We don't normally have it, but again, there's a lot of inflammation going on in this patient's back, and that's why we're here. So, okay, laser off. We're done. Hope you enjoyed this surgery, and I hope I have some fresh coffee to drink. Scope off. Any questions? If you have a question, feel free to type it up. We don't charge to answer questions. Not today. You didn't take the suction off, did you? No, because I'm not really seeing much suction. One more irrigation. So we've got 2 tiny little incisions. We did the whole surgery through those 2 little incisions. Here you go. And I'm going to show them to you. One was on the left side, one was on the right. And I think this patient will do really well. I know they're going to do well. And the reason I know is because, well, we tested the discs and they were definitely painful. So I know from the MRI they're hitting the nerves, so I know the leg pain is going to be better. But I also now know from the discogram that they were causing all of her back pain. So I feel really confident that she's going to do really well with the back pain. Okay, so everyone can see the whole surgery is done through this little tube. It looks like a shake straw made out of metal. We call it the, I can't really say McDonald's anymore because, gosh, McDonald's has gotten in trouble recently. Did you all see the news about the lawsuit from Jamie Oliver? Jamie Oliver is a British chef who is basically accused McDonald's, and rightly so, of selling toxic meat in their hamburgers, and apparently McDonald's fought him and he won. Apparently, that's what I've heard. Now, is it? I haven't seen the lawsuit documents, but yeah. So I don't know if I can say McDonald's shake straw anymore. Okay. Did you see? Do you see the incision here?
Yes, we saw it.
Awesome. So tiny 7 millimeters, both of them. We're going to put a stitch and then close up, and we'll get this patient awake and probably home in an hour. So type your questions up for me. I'm going to come and answer them for you. All right. We've talked about a lot this surgery. I feel like I haven't stopped talking. But if you have more questions, happy to answer. We got 4 more surgeries to go today. EBL 2 mil, no complication. DLDR.
Deuk laser disc repair, a comparison with traditional spinal fusion surgery. A patient with chronic back or neck pain originating from a symptomatic disc injury could undergo either traditional spinal fusion or less invasive Deuk laser disc repair. This MRI represents a typical case with L4-5 and L5-S1 symptomatic discs. A symptomatic disc causing neck or back pain can include bulging discs, herniated discs, ruptured discs, degenerative discs, protruding discs, spinal stenosis, radiculopathy, and sciatica. This patient can choose traditional fusion surgery or the Deuk laser disc repair to help alleviate the pain caused by and within the symptomatic discs. Here, 2 patients with comparable disc injuries are treated. On the left, the highly invasive spinal fusion, and on the right, the least invasive Deuk laser disc repair. The spinal fusion requires a very large incision, usually leaving a large scar. The Deuk laser disc repair requires only a very small incision, usually less than a ½ inch long. In this small opening, a cylindrical rod, called a dilator, is inserted to gently spread the muscle to create a small passage and guide through which the surgery is performed endoscopically. The incision for the fusion continues, including penetrating the skin, fat tissue, and multiple layers of muscle through to the bone. With the Deuk laser disc repair, a mallet is used to advance the tip of the dilator into the symptomatic disc. A tube, called the tubular retractor, slides over the dilator and is carefully positioned into the disc, again using the mallet. The rest of the entire Deuk laser disc repair surgery will occur inside this narrow tube. To access the spine, the spinal fusion requires the muscle to be separated from the vertebrae. This very invasive action causes trauma and permanent damage to the muscles. Whereas in the endoscopic Deuk laser disc repair, the muscle is not damaged. The endoscope camera is inserted into the tubular retractor to allow the surgeon to guide the laser inside each symptomatic disc. To accommodate the fusion hardware, a large bone grabber is used to perform a laminectomy by removing bone from the spine. The fiber optic laser used in the Deuk laser disc repair is manipulated with great accuracy to remove only painful inflammatory tissue from the disc. In this highly magnified view, the laser is used to precisely remove damaged disc material that is causing the pain. The laser is debriding, or essentially vaporizing, damaged tissue in the disc's outer layer, or annulus, specifically at the annular tear, the source of the rupture or herniation and pain. After the fusion patient's damaged discs are removed, a metal or plastic cage housing bone grafting material is inserted in place of the removed discs. Once the laser has removed the painful part of the annular tear, the endoscope and tubular retractor are removed, leaving less than 1/2 inch incision in the skin, which is closed with a single stitch, Steri-strips, and a Band-Aid. Total time for the Deuk laser disc repair surgery, approximately 1 hour. The fusion, however, is still underway. Holes in the spine must be tapped in preparation for the large pedicle screws that anchor the fusion hardware. The Deuk laser disc repair patient is in recovery usually 45 to 60 minutes before released to go home. The fusion screws are inserted into the bone, as shown in the X-ray. After all screws are in place, rods are used to connect the screws together to prevent movement of the secured vertebrae. Cross-links are added to bridge the rods together for additional stability. Fusion hardware, by design, is to fuse joints that normally move, preventing natural movement in the damaged portion of the spine. Whereas with the Deuk laser disc repair, there is no loss of movement. Normal movement and flexibility of the disc and joints is preserved. The Deuk laser disc repair patient is soon back home, enjoying life, with a very fast recovery, allowing normal activities without pain. Meanwhile, bone graft material is placed throughout the fusion surgery site. These morselized pieces of bone will eventually grow together to help promote the fusion process. Prior to closing the wound, a temporary drain is installed to allow excess fluid to drain. Average surgery time of a traditional 2-level fusion is 2.5 hours, with an additional 3 to 4 hours in the recovery room. As we've seen, in comparison, a spinal fusion requires a much larger incision and
Alright, and you will be ready in 3, 2, 1.
Hi there, I'm Dr. Deukmedjian, and we're just finishing up surgery on a patient who has suffered with back pain and pain going from the back down both legs. So we saw this patient in clinic and looked at the MRI scan, recognized that there was damage to 3 discs, and the patient was having pain. Basically, if you look at the model here, these are bones called vertebrae. The white things are the discs between. This patient was describing back pain in this area. And so, just a side note, it really, it surprises me and disappoints me to a degree, but I hear stories all the time about patients that come to me, they're in pain, they've been in pain for years, and I ask them, have you seen a doctor for your back pain before? And their answer is always, yeah, I've seen many doctors. And then I do my exam on their back to figure out where the pain's coming from, and they say, my doctor never examined my back. And it's sad, but it's just crazy to me, because how can you tell where back pain's coming from if you don't examine the patient's back? So the first thing I do when I meet patients, of course, I say hi, shake their hand, and then I ask them to stand up, turn around, and I ask them to take one finger and put that finger on the worst spot where they get the worst pain. And of course, most of them are able to do that right away, but some of them, they have pain all over. And I say, well, that's probably the muscle spasms causing muscle spasm pain, but where is your worst pain? And they'll put their finger on the worst pain. So this patient we just finished, now she had pain in an area that I mapped out to be L5-S1, L4-5, and L3-4. So I knew I was dealing with more than one painful disc, okay? I don't ever decide what surgery to do just based on the MRI unless the patient has one bad disc and it's obvious. And let's say they have a herniated disc at L5-S1 to one side, and they're having back pain at L5-S1 right at the belt, and the pain is going down their left leg, and they have a herniation on the left side, and all the other discs are normal. Well, now I can pretty much say, well, the MRI is showing the actual source of pain. But when people have more advanced disc disease, that means they're having multiple disc herniations, maybe even 3, 4, 5 of them in their back, some facet disease like facet arthropathy. And now I don't know on the MRI where the pain's coming from. It's impossible to know. So I have to have the patient show me exactly where their pain is. And like I said, this patient showed me pain at 3 discs preoperatively. I confirmed that on the MRI, L3-4, 4-5, 5-1. And because they had pain going down both legs, I had to go on both sides of the spine to treat the irritated and pinched nerves, okay? So we just finished with her surgery and it was successful. I apologize that it wasn't great visibility for you because there was constantly a little fumarole of some red blood cells at each disc, which kind of obscured your view. It obscured my view as well. It makes it harder for me to do the surgery, but I've learned a few tricks over the years about how to deal with it, and I showed you those tricks by putting in the grabber. It actually slows down the flow of fluid through the tube, the irrigation, and it allows the bleeding to kind of become pressurized and stop because there's some back pressure I create. And that allows me to see what I'm doing for just a split second. Then I go back to the laser. So what question do we have from the
Okay.
audience?
So it's a previous question from Facebook. If a patient can achieve union, would you debride the joint of debris or leave it as non-union? He also adds, it's like if the bone graft doesn't fuse.
Yeah.
Wants you to explain that.
All right. So one of our viewers is asking, what happens when someone does a fusion? All right. All right. Let me use this over here because this is a better model. Can you all see that? I know you could probably zoom in a little bit. All right. So let's take a look at this thing here. What's happening here? Well, this is what we call a segment of the spine. You have a vertebrae here, a vertebrae here. These are called the vertebral bodies. They're the big part in the front and middle of the spine. Then you got the we call the posterior elements in the back because there's several of them. You have spinous processes, lamina, facet joints. So what we've got here is a typical, what's called a transforaminal lumbar interbody fusion, or TLIF. You could also call it a PLIF. And you've got screws going into the pedicles there, 2 screws, one at L4, one at L5, another one at 4 and 5, and then a rod to connect them. Now what these screws and rods do is they stop the movement of the bones, which is what you want when you're fusing. Because anytime bones are moving, you know, with respect to each other, if they're moving during the fusion process, the bones aren't going to fuse. You're going to get scar tissue instead. And that's what this person's asking about. They're saying, what do you do when you're supposed to be fused, but you don't have solid bone in here growing from one body to the other, making one piece of bone, one solid, strong piece of bone? What do you do when there's just scar tissue? So let me explain what fusion's all about. The idea behind fusion is that you're going to take a painful joint, a joint that hurts to move, okay? And if you fuse the bone above the joint to the bone below the joint, then there's no more joint, so you've gotten rid of the source of pain because there's no movement and there's no joint. This was great way to treat painful joints for many, many years. And originally when people had knee pain, like arthritis in the knee or hip pain, the surgeon would go in there and grind up the surfaces of the bone above and below the knee joint and pack some bone in there and fuse it. And so their knee pain would go away, but they would walk with a stiff leg. So you lose the movement, but you lose the pain. The compromise of losing movement is not good. So surgeons then developed alternative treatments like artificial joints. So we have artificial hips, artificial knees, artificial shoulders, artificial finger joints, and of course artificial discs for the spine. So the purpose of the artificial joint is to remove the painful tissue, the soft tissue in between the bones, but preserve movement through the metal joint. Well, when it comes to fusing the lower back, it's the same concept. You want to fuse one bone to the other. To do that, you've got to pack bone in between the bones, into the disc space, okay? It's called an interbody fusion. Now the fusion, we call it a fusion during surgery. We're fusing the bones, okay? We're going to fuse your bones. But the actual fusion doesn't happen during surgery. The actual fusion happens after surgery. And it takes about 3 to 6 months, maybe even a year in some patients, where your bones grow together. And that growing together is you, the patient, making the bone. So the only thing the surgeons can do is like prime that joint for fusing. So how do you do that? Well, you want to pack bone in there and you want to stop the movement between the bones so that it's still and stable and it allows the bone to grow. Plus you want to add some compression on the bone because compression, Wolff's law, allows bone to grow better between the surfaces, and it allows fusion to occur. Think about it. If you break your arm, what do? We take the broken pieces of bone, put them back together so they're opposed to each other, you know, and then we put you in a cast or put in fixation, which is rods and pins. And what we're doing is we're stopping movement here at the joint, and that allows fusion to occur. So what happens when fusion doesn't occur? Well, when fusion doesn't occur, instead of getting bone growing across, you get scar tissue. And that's really what this person's asking about. They're saying, I've got scar tissue between my bones. The fusion never took. What would you do? I would do nothing. Okay, that's the short answer. This is a long run for a short slide. Do nothing unless it's actually causing pain. So your answer is going to be, well, it is causing pain. How do you know it's causing pain? I've been doing this 26 years. I know far more than any other doctor I know about non-unions and back pain. And I can't even tell you that your failed fusion is the cause of your pain. So I can tell if I can examine the patient's spine and see where their pain's coming from. But I can't tell you how many patients have been shocked by the fact that their pain's not coming from the failed fusion. It's coming from the disc above the fusion or below. So my advice to you is don't assume your failed fusion is the cause of your pain, okay? There have been studies on this done and published, and it turns out that most of the time, failed fusions are still stable enough because of the screws, rods, and scar tissue that they don't cause any symptoms, they're not unstable, and they don't need to be fixed. And that is 9 out of 10 times at a minimum. So like I said earlier, I've seen 1,000 failed fusions in my career, and only about 5 in 1,000, 5 patients out of 1,000, the pain was coming from the failed fusion. Okay, again, 99.95% of the time, the pain is coming from the disc above or below. All right. That's all the questions we have, and I've got a phone call, so we'll see you soon.